Hey, I think we got something working here.
I think so too.
Hold on now. I've just got to play with how to do the setup. There's a way. That is the weirdest thing. Like I am like try to let's see here. Let me get your video on.
Oh,
We'll get there, I promise. There we go. There's that. But
okay.
don't need to be small like that. So there's a way to change it to panel. So I'm getting there.
Okay.
Expand.
Okay.
Hey, that. We're getting there. Hey, we'll get this in a sec.
Yay.
We'll figure out how to do this. Give me one sec.
Okay.
At some point, I'll get in the video myself.
That would be great.
Well, let's see. One more thing.
I can see people joining.
Yeah, no, yeah. You'll be surprised. Once we get going, it'll get kind of nutty. I may just minimize myself. The problem with it is that I don't have, you can't really see my stuff. So I feel kind of bad about that. Like that's what like our video board in the back is.
Minimize me. You don't need to. Let me read this way. So why don't you minimize me? Let's look at the board. That's more important.
Let me figure out how to do this.
Okay.
This is good thing about going live. It makes life fun.
That's fine.
Does that work with you? Okay.
Perfect.
Let's do that. I also gotta get, come on a second. All right, can you still hear me?
I can hear you.
All right, good. My problem with it was I was trying to rig up my microphones like I always do, but when I did that, I wouldn't be able to hear you talk. So
No, okay.
awesome. All right. I assume you can see me all right.
Yes, I can see you fine.
Yeah, and let me get this up live too so I can follow questions and we will get going.
All right. Sounds good.
Let's go here. All right. Make sure everything's good. Very good. Well, awesome. Thank you so much for joining us today. Little technical difficulties, but we finally got there. I'm Steve Hofford, owner of Magnolia Pharmacy, pharmacist, entrepreneur, also had the Trusted Pharmacist Podcast. But even more importantly today, I'm super fortunate to have my awesome friend and guest, Dr. Sakina Davis. I've already told a little bit about myself. Sakina, if you don't mind, tell everybody who you are, kind of what your background is, where you practice at.
Sure. Thank you for inviting me today. This is such an important topic. I'm Dr. Sakina Davis. I own Woodlands Wellness and Cosmetic Center. I'm functional medicine trained for the past 20 years. I am practicing in the Woodlands, Texas. I've authored a book about PCOS, and I am board certified in functional medicine.
Very cool. Well, it's awesome to have you join. And the thing about that kind of triggered our conversation, Sakina and I the other day had lunch and we were sitting and talking about how, you know, we've been working with patients for 20 plus years apiece on trying to help with menopause. And I think we're pretty darn good at it. But more importantly, we appreciated the opportunity for somebody like Oprah Winfrey to bring on some name brand guests and really talk about menopause and shed some light and stuff. So we both watched it together. We both made some notes. We also talked a little bit afterwards. You're like, hey, let's have a discussion on TikTok Live and let's try to figure out how we can share the message about menopause, what we've learned over the year, but take a little deeper dive because we both agreed the special was, you know, it was good. It was great to bring up the topic, but all it did was kind of launch the topic and then it kind of left it. And that's kind of what we jumped in. Sakina, give me your thoughts about it. I really think the program did a great job of really highlighting how important this is and how it affects women's health from their physical health to their mental health and their families, their communities, their children, their marriages. Kind of give me your take on what your thoughts were from the menopause revolution with Oprah.
Well, I was really excited that they brought on these exciting guests, as you mentioned. And really, I think it was just opening up the conversation, which has been closed for so many years. You know, back in 2002, I remember distinctly when that DHEA study came out saying that hormones are going to cause cancer, because I was on maternity leave with my daughter. And the phones blew up and everybody didn't know what to do. And people were crying, what do we do? And so that really threw hormones into a tailspin. So unfortunately, that data was never correct, but then never clarified. And so I think they try to make that point also on the Oprah show. And so I was just so grateful that now, 20 years later, I think we're finally opening up the conversation again. And we're starting to let people know that hormones are not going to kill you. They're not going to cause cancer. They're not going to kill your heart and your brain. In fact, everything is the exact opposite. So I'm very excited that she did that show, but I was disappointed that they did not give us more information. But of course, they only had 1 hour. So that's why you and I are here, so we can dive deeper. Uh-oh, I think Steve, there you go.
I lost you for a sec. Yeah. Welcome to the world of trying to make sure the internet's working. Yeah. And I would agree with you on what you just said, is that I think the special did a great job of taking the box off of things and saying, hey, let's start looking at this again. Because I think you would agree with me. There's definitely been a big change in terms of not only in our profession, in terms of a functional root cause approach, personalized medicine, whatever you want to call it, but even more so, I think even the medical community that was kind of at one time, some of the menopause organizations and the OBGYN groups, they're even saying hormone replacement is okay now. Is that kind of what you're seeing also too?
Yes, which is shocking to me, because 20 years ago, everybody wanted to condemn me for what I was doing and talking about, and you too, I'm sure, but now at least we're being vilified, like, okay, we've been doing the right thing all along and now it's okay. But for 20 years, we had to fight the fight, Steve, didn't we?
No, that's for sure as far as that goes. So what I want to say throughout this TikTok live, we're going to be on here for a while. This TikTok live is for you to ask questions. Like I mentioned when I did my post today, between you and me, we've got about 40 years of dealing with this. A lot of times I get picked on for saying, why does this guy want to talk about hormones? This is a guy, he don't get it. But I can tell you, and I know you do, Sakina, because it's the world you live in, and what you do for a living is, between both of us, I know we've helped thousands of women through menopause to be successful. And this is your opportunity to kind of pick our brain and have that opportunity. So just as a start, we wrote a couple questions down behind me we'll kind of start with. But I know one of the things that I mentioned is just like, what is menopause? In your eyes, like how would a patient walks in your office, they sit down on your table and you're talking about things. How do you explain what menopause is to a woman?
So I think it means so many things to so many different women, first of all. So the true definition, of course, means that we don't have a cycle for 12 full months. But the things that happen before that can happen for years prior to that. So perimenopause is another topic that we really need to discuss, because for some women, it can occur up to 15 years before they reach menopause. And that's the time when all of your symptoms go crazy. When you start having more PMS, your cycles start changing, you have a change in your sexual health. I mean, there's joint pains, there's brain fog, there's so many things that can happen as your hormones start to decline. So when our eggs are finally deciding that they're no longer going to respond to the hypothalamus pituitary gland, that's when menopause occurs. And those 12 months can be a rocky road. So I try to explain to most women that it's not like it just shuts off one day. It's not like a faucet that we just turn off, but it can be years and years of roller coaster of hormones changing.
Yeah, and that was one of the neat things I think they brought up on that special, and I would agree in the very beginning, they kind of gave the visuals, was talking about, for some ladies it's even earlier, but it's about that age of 35 when those progesterone levels kind of first begin to change is when this stuff happens. And so, yes, even at 35 years old, and even before with some ladies nowadays, I think you see it even younger, yes, hormonal changes start to happen, and it is all about balance. And when those things get off balance, that's when it sets people up for, sets up a woman to start those changes. And like you just said, this isn't something that happens overnight. It takes months and years for it to happen. So maybe you don't notice things initially happening, and then over time you're like, oh my gosh, like my body's really different. How I feel's different. My energy's different. I work out and I don't get the benefits like I used to. And then it's all about fixing that. And I just want to stress, as we keep talking, we've got stuff to talk about, but drop your questions in the comments and I'll be more than glad to read those out and we'll answer those together as far as that goes. And understanding that. So let's talk a little bit about HRT. So that's hormone replacement therapy. It is replacing hormones. And like, that's the big, I would say is to me is the big taboo right now is, are hormones safe? Who are they for as far as that goes? We know when you sit down and you start the process of going over hormones with somebody, what is that conversation? How does that conversation start about hormone replacement?
Well, first, I try to alleviate their fears. I think so many women have been, again, taught from that 2002 study, and then just years after that, and their cardiologists tell them and their neurologists tell them that hormones are not safe for women. So first of all, it's really battling all of that. It's trying to explain to them that hormones, well, and of course, I like to use bioidentical hormones, which there's a key difference between synthetic hormones and bioidentical hormones. And I'll let you go into all the specifics about that. But bioidentical hormones for sure, of course, match our chemistry. And if we're trying to balance our chemistry, how can that kill us? That's what I don't understand, you know? So if we use a hormone like Premarin, which comes from a pregnant mare's urine, hence the name Premarin, that's not going to work for me because as far as I can tell, I'm not a pregnant horse. So I really feel that bioidentical hormones, using them, monitoring them, I like to use urine metabolite testing to check and see how my patients are metabolizing their hormones. We can use serum testing or saliva testing to test where their baseline is. There's so many options of how to test and how to test correctly. The other issue is that there's such a broad range when they go to their physicians who unfortunately are not well versed in hormones. They're told that everything is normal. And even if their progesterone is 0.003, they're like, oh, it's normal. So that can't be normal, especially if their progesterone's, less than 5 and their estradiol is 195. That can't be normal. So I think, again, it's really important that we explain to them that the ratios are important, that hormones are important, that testing is important. And then I do everything that I can to explain to them that this is not in a vacuum. So if you take hormones, or you don't take hormones, we still have to protect ourselves from cancer with our lifestyle. So exercise and sleep and nutrition. And nobody seems to think about that because they'll go off and drink, 3 glasses of wine and they'll use all those chemicals in their hair and nobody's thinking about that. But hormones are going to kill you. So that's, that's why I try to explain to them that everything has to be a balance.
That's a great characterization of what it looks like. And once again, anybody that's just joining us now, I've got myself, a pharmacist. I've got Dr. Sakina Davis, a medical doctor. We're talking about menopause. We're taking a little deeper dive into the menopause conversation after the last Oprah Winfrey special. So if you've got questions, be sure to drop those in the comments. Definitely would like to answer any of the questions that you might have. So you covered like a vast array of information right there on hormones. And I think one of the things you brought up is that whole what's natural, bioidentical. There's a lot of different terms being used right now. But I think what people don't realize is that when we do hormone replacement, we put the exact same chemical in the body that the body made. And the important thing to understand about that is that if it's not a synthetic, it's not kind of like what the body made, it's exactly what the body made. And so the real benefit with that is understanding is as long as it's dosed properly, the body handles it properly, metabolizes it properly, and we do a dose physiologic or like what the body made, you get all those benefits. Because I was reading a study the other day that talked about a hot flash in women is thought of, it's a nuisance, right? But they were linking ladies who have hot flashes, and sometimes the intensity of those hot flashes is directly correlated to their cardiovascular outcomes. And that's because as these hormones get out of balance, what's important to keep in mind is these hormones, like you said, they just don't work in terms of just helping you have a baby every cycle. There's receptors for these hormones in your brain, on your heart, and your kidneys, your lungs, your skin, your bones, everywhere in the body. And these hormones are so important to be balanced as far as that goes. And like we talked about is in your practice, Sakina, in terms of replacing hormones, what are like what are them 3 or 4 main hormones that you're typically looking to replace or that you test and find that women are low in?
So of course, my favorite hormone to test for is progesterone because that's the hormone that tends to decline early in the late 30s, early 40s. And that's the hormone that I call our feel-good, happy hormone. So with it, you sleep better, you don't have night sweats, your moods are better, your anxiety is better. So I love my progesterone. Of course, we check for estrogen. That's super important for 1,000 other reasons besides hot flashes. It helps with vaginal dryness. It helps with brain fogs, colon cancer protective, brain protective, joint protective, skin protective. So we can go on and on and on. Of course, testosterone is super important. That's been, an issue for many years as well. Do we give women hormone replacement with testosterone? Of course we do. We make testosterone. We need to replace testosterone, but not every single woman needs it. That's what we need to identify. Okay. Estrogen, progesterone, probably 95% of women will need estrogen and progesterone. Not every woman needs testosterone. And then I check for DHEA, which of course is also our great feel-good hormone, helps with energy, building muscle, so many different symptoms.
I think you brought up something really good there, talking about that perimenopausal woman that's like that 35 to 45. And a lot of times, it's not a guarantee. That's why you test. Right. But most of them, it's just really more of an inadequacy of progesterone in relation to estrogen, and that what we'll call estrogen dominance, or that imbalance, leads to those things like mood swings and irritability and breast tenderness and inability, they have a hard time losing weight, and just all the emotional roller coaster of having an imbalance of hormones. And you nailed something. Like, progesterone's a pretty awesome hormone in the sense that, especially like if you're having like sleep and anxiety issues, it's a really good hormone to replace, and that's not uncommon. The problem that I see with that, and you'll agree with this, a lot of practitioners that aren't trained in hormone replacement will commonly stick those patients on birth control pills, or not progesterone, but progestins, which are crazy because really, in my opinion, yeah, it may help with some cycle irregularity issues, but it just makes all those other problems worse because that progestin that's synthetic binds on the same receptors that progesterone sets on, and actually can block your natural progesterone from doing what it's doing. And these progestins are very inflammatory. Like, they make all these other problems worse. So it's almost like we make the problem worse because doctors don't realize, we need to give progesterone and not progestins. And I think that's a big issue for a lot of ladies on birth control. Do you see that sometimes yourself?
No, all the time. I test all these ladies. Of course, on birth control pills, I can't test anything because there are no hormone levels to test. But on the Mirena or the IUDs, we also see that progesterone levels, when I test them, are very, very low. And I think that's been a huge issue because I know a lot of women enjoy not having their cycle with those IUDs, but by putting that Band-Aid on, we're not doing a good job for their bones. We're causing more estrogen dominance. And I think that's what they don't know until sometimes it's too late. And now they're leaving those IUDs in for now 7 years and 10 years. And I think that's complicating things even more because I'm seeing them gain more weight and have more side effects. So, that's become a real issue. I think that the progestins are definitely causing, in my opinion, more side effects and issues than actual progesterone.
And you nailed it. I get asked that question a lot about IUDs and those progestin IUDs. And I think sometimes ladies even forget, like, those have hormones that actually work against you. Yes, it is nice in terms of the other things, but it's like the long-term side effects of doing these synthetic hormones and their overall effect. Let's talk a little bit about testosterone. So surprisingly, and I think you would agree with me, I think we test a lot of ladies, and these are ladies in their 30s, and their testosterone can be in the tank. It's not for everybody. We don't just give it, you probably understand this. People talk about sex drive and libido and think, oh, that's a testosterone issue. And you and I both know there are many other things that can affect sex drive and libido. But on the testosterone replacement side of things, in your opinion, what are some of the other things for ladies who are low in testosterone that you see them get benefit from taking testosterone?
Oh, I think that their energy is better, their focus is better, they build muscle, which is so important now. We're really realizing that muscle and protein are so important to keep us going in our 40s, 50s, and 60s. I think we didn't give that enough importance in years past, so that's become huge. I think definitely being able to concentrate more, and then, of course, leaning out. So I think there's huge benefit from an appropriate testosterone level. I do think that there's some issues with excessive amounts of testosterone, and of course we can go into pellets there, which I do believe that pellets can be helpful for some women and men, but I don't think that they are for every single woman. So I think you have to be very careful when you are getting pellets, because now, unfortunately, they're sort of being given everywhere, every med spa and every facility, and I think many of those can be too much for women because then they tend to lose hair, or they tend to gain weight from the excess amount of estrogen. They tend to grow hair in their face or other places. So there can be a lot of side effects. So we have to be balanced. That's the key. And not every woman needs a whole lot of testosterone. A little can go a long way.
Yeah, and that's a great point. And just keep in mind, if you're joining our TikTok live, keep in mind I see a lot of people are joining and you're new. Make sure you drop your questions in the comments. You've got some hormone experts here that can ask your questions. One of the things, questions you just come in, Sakina, ladies asking, I'm in perimenopause. I've got symptoms, but my doctor checked my levels and they're normal. And you would agree with me on progesterone, especially. And then there was like, why would my doctor still give me progesterone? But you and I both agree it's about testing and symptoms. We don't just guess off of symptoms, because sometimes it's crazy. Too high and too much and too little estrogen look the same with symptoms. Too much and too progesterone could look the same with symptoms. So you can't guess. You really have to test. But one of the things about progesterone I think is a challenge is it's very, depending on where you're at in your cycle, has a dramatic impact in terms of testing and what would be normal and not normal. Because you and I both agree, like if you checked on like probably day 5 of your cycle versus your progesterone level on day, say 21 of your cycle, they're going to be radically different. So they were just asking, why would my doctor still provide progesterone? And I think in your opinion, if they're having a lot of symptoms, would you recommend a test on different times, or do you specify specific days you like to see testing done?
Absolutely. They need to be in their luteal phase. So if you have an IUD and we don't know when you're going to have a cycle, that's a little difficult to do. And if you're obviously not having cycles, then we can test you at any time. But if you are cycling, then you need to be tested days. We have a window of days 19 through 25 if you have 28 to 30 day cycles. If you have a longer cycle or shorter cycle, we adjust that. But if somebody just randomly tests you on day 2 or 3 of your cycle or don't ask, then they don't know what they're testing for, I'm sad to say, and they don't know what normal actually means.
Yeah, and that's sad. I doubt probably even most practitioners, they'll just run a hormone panel and never even think to ask, like, hey, what day on your cycle are you? Which is kind of sad. Another question just came in. This is a good one too, because I get asked this a lot. If a woman has high cholesterol and she wants to take HRT, does she need to lower her cholesterol first before she can get on HRT? And that's really a loaded question, because I think we know the benefits in terms of hormones and cholesterol.
Okay, so first of all, if you want to lower your cholesterol, get on HRT. That's the key phrase right there. So if you think your cholesterol is high and you're going through perimenopause and menopause, guess what? It's because your hormones are changing. So we need to balance your hormones, and that is going to help you lower your cholesterol. Now, if you're eating, McDonald's all day, okay, that's a different story. But, but it's really that you had great cholesterol and things are changing, insulin resistance, all of those things change when your hormones change. So absolutely, positively get on HRT, the right kind of HRT, and of course, look at nutrition as well.
And you brought up something too. I think we see this a lot. Without good hormone balance, things like insulin resistance have a bigger impact in terms of negative cholesterol with metabolic syndrome issues. Seems like a lot of ladies in this menopause will have a lot more stress. High cortisol can run up the cholesterol. There's all these different things, but you are right. There is so much data out there to show not only would I not be worried about it if I have cholesterol, but your hormone replacement can actually benefit that. So that's a good point as far as that goes. I'm looking at this. I'm looking at another question. It said, started estrogen 0.25 and was hoping to feel better. Wasn't helped. I'm exhausted. The question I have on something like that is, okay, you started estrogen, but did your doctor also start progesterone? Do you see that kind of often, where maybe the old mantra of, you don't have a uterus, you don't need progesterone? Are you still sometimes?
Yeah, that drives me crazy. Okay, progesterone has 1,000 uses besides protecting your uterus. So please don't let people tell you that you don't need progesterone because you don't have a uterus. I explain this to my patients by telling them that conclusion came because years and years ago, they did a study where they allowed women who had a uterus to take estrogen only. And guess what? They developed uterine cancer. And so then they realized they needed progesterone to protect the uterus. And there they made the conclusion, I guess if you don't have a uterus, you don't need progesterone. Now, what kind of conclusion is that? They don't even look at all of the purposes and reasons why we need progesterone. So yes, that one drives me absolutely insane. Take your progesterone and get balanced.
I've heard it said once that a lot of this previous stuff was done with a bunch of men running the show and making the decisions. Yes. And all they really thought about in terms of prescribers is, if you think of estrogen as the gas and progesterone as the brake, well, we've got to make sure if we're giving estrogen that we give that progesterone to basically balance in that uterus so we don't have excess uterine growth and all the problems that come along in terms of unopposed estrogen. But, oh, that uterus is gone. We don't need it. But unfortunately, if you had a hysterectomy, they didn't pull the progesterone receptors out of your brain and all the other parts of your body and your gastrointestinal tract and your heart. So that balance is so important as far as that goes. And so that's a great way that you put that there. So I like the comment as far as that goes. Let's talk about a little bit in your practice and what you do. Let's talk about like the main hormones you do. What is your preference in terms of replacing hormones? Are you like a cream person? You like capsules? You kind of mentioned pellets a little bit earlier. Give me your thoughts about hormone replacement and the favorite ways that you like to practice and use that in your practice.
So I like to do what's best for each patient. So I do like to personalize it to them, first of all. That's very important. And so when we're given these two hormones by many of our famous physicians talking about hormones, about estradiol patches and prometrium, certainly that's an option, but let's explain why that's not my favorite option, right? So progesterone or prometrium is not really, it is bioidentical micronized progesterone, but it contains peanut oil and other fillers, which are not good for us. So we're all on this kick right now of avoiding seed oil. So why would I want to put back in my body a progesterone that has a seed oil in it and other fillers that may not work as well for me? The estradiol patch is wonderful, except that it misses the hormone estriol, which is one of our most important estrogens as protective for breast cancer. So again, they're an option, but for me, I prefer to use bioidentical compounded progesterone because I can send you, Steve, any dose I want. I can send you a 5 milligram, a 10 milligram, a 100 milligram, a 300 milligram, whatever I want. And so progesterone capsules are usually best for sleep, for anxiety, for moods, and I find that's my most favorite form of progesterone. But we do use it topically in some women. We do use it in troches in some women. With estrogen, my favorite way to replace that is with topical because, again, using it orally can increase your blood pressure. It can increase the risk for strokes. So I like to use that topically if I can. That doesn't mean that I've never sent you a prescription for an oral estrogen. Of course I have, because in some women it may just not absorb correctly. And then for testosterone, I like to use either topical or sometimes I will use these little lozenges called troches because women who have young kids, sometimes I get concerned with them applying a cream and then carrying their babies or young children. So I do give them the option of using that. So, so we use a combination. Yes, for some women, we do use pellets if I feel like it's the best option for them. If I've tried everything else and I'm not seeing good response and I know their body can metabolize it. So I do use pellets, but that's probably honestly my least favorite way to replace hormones.
Gotcha. Yeah. And once again, if you're joining our TikTok live, keep in mind we're discussing menopause. I've got myself, a pharmacist trained in hormone replacement. I've got Dr. Sakina Davis, who's also trained in hormone replacement, to answer all your questions as far as I go. So keep dropping those in the comments as we go along. So you brought up something there that I think is critical to understand. And you mentioned that there are a few commercially available, what I'm going to say, bioidentical or natural products. But what I've learned about this, it is very individualized. This hormone replacement, it would be really nice if we could come up with 5 strengths of patches and 2 strengths of progesterone to cover every lady that needs hormone replacement. But you and I both know that is not a possibility. Mm-hmm. And that's where compounding comes in. And I'm a compounding pharmacist, but I'm not here to push that. But I'm trying to say is if you honestly want to come up with a personalized, individualized, right dose for each patient, there is a time that compounding is needed. You brought up a good point. During these menopause years, I think hormone replacement is a huge piece of that puzzle. But other than hormone replacement, what are some of the things that you have your female patients work on to help get the most out of their hormone? What are some of the holes that you plug that make these menopausal symptoms worse?
Well, first it's going to be sleep, because if we're not sleeping, we're cranky. And I know that because I'm in menopause myself, ladies, or men, if you're with us. So it's definitely important that we sleep. So we start working on better techniques to sleep. We add supplements if we need to, like magnesium or melatonin or L-theanine. So many different great things that we have. We help, your stress. So yoga, meditation, some type of stress modification is really important. No one's going to not have stress. I wish we could live in a stress-free world. That's never going to happen. So trying to do something to modify that stress. And then nutrition is huge. We all think, we can eat whatever we want in our 20s and 30s, and then what happens? Well, guess what? Our metabolism changes, and it's not a pretty picture out there if we're not learning to adapt to that, right? So we have to change our diet. We have to eat more protein. We have to eat more fiber. We have to eat more vegetables, more plants. We have to eat more good fat. We need to minimize those carbohydrates, those starches, that processed food, fast food. All of that is just not going to work for most women as they transition into menopause. So it's nutrition, it's stress, and it's sleep. Those are our big 3 plugs that we try to fill.
Amen. And then all those tie in to help improve your gut health. And so, yeah, you nailed it. That's so critical. It isn't just, let's throw some hormones on board and hey, everything's going to be great. We have
right.
Hey, here's a great question actually. And I like this one. And I think this is a good, it says, can I use testosterone cream during perimenopause with a history of polycystic ovarian disease and acne? So that's a little complicated. I know whatever as far as that goes, but there's just some red flags that go up there that made me think, why are we even looking at testosterone for this? What are your thoughts if somebody asks you that question?
Well, my thoughts are we need to test. I have PCOS myself and I've had acne myself. So I can empathize with you completely. But we do lose our testosterone in perimenopause and menopause, even with PCOS. So the key is to test your testosterone and to test its metabolite, dihydrotestosterone. See how we can manage that. And guess what? All those nutrition changes I just mentioned are the things that help you to not convert to dihydrotestosterone, which is what is responsible for that acne. So if you're low in testosterone and you're needing it, we just need to make sure you're not converting to its metabolite, and we need to use it correctly and safely. And you absolutely can use testosterone with PCOS and perimenopause.
And you nailed that. I think that's one of the keys is I think controlling that insulin resistance in PCOS is so critical to help balance hormones. And then I think you would probably agree, and we'll see, but testosterone can be important if it's low. We don't always see that. I think you can sometimes see that it can be low, but a lot of times, obviously, that can be a driver. But one of the things typically, too, is a lot of those ladies can really benefit from progesterone, and as far as that goes. But you are right. I would definitely want to test, and I think that's the part that gets missed sometimes is that providers don't really test. Let's talk a little bit about stress and cortisol. You brought up a good point, and I think from my early training is you and I can fix somebody's hormones perfect and put them dead center of normal, that they're doing rocking and rolling good. But if they have a lot of stress and a lot of cortisol, they're still going to have a lot of menopausal type symptoms. Would you agree with that or disagree with that? And then what are your thoughts on that?
Well, cortisol is a big driver of all of our hormones, right? So if our cortisol levels are out the roof or they've exhausted to nothing, it's definitely going to impact all of the other hormones, and unfortunately negatively. So if we don't get that stress under control, we can get you perfectly straight on the levels of hormones, but they're not going to work as well as we want them to unless we get that cortisol level corrected as well.
No, that's a good point. I just see so many patients come in that one hormone replacement, but have lives. And unfortunately, that's the challenge of menopause. And I think you would agree with me. Many of these women are burning the candle at both ends. They've got hormone issues. They're taking care of a sick family member. They're still taking care of kids. They're having to work multiple jobs. They're maybe in a stressful marriage. And on top of all that, their hormones are out of balance. And on top of that, their cortisol is high, which just sets up a female and a woman that's going through perimenopause and menopause for such a challenge. And that's the part, like, I do appreciate the Oprah special, because I really feel like it kind of brought out the need for having a discussion that, look, and I say this all the time, and I think you would agree, at some point as a female, you better take control of this. You better start looking at fixing all these things, replacing hormones and doing all those things you mentioned beyond hormones. Because if you don't, at some point, you're going to break down the health, and you can't get back to your health, and you can't buy that back. Because the point is, if you're taking care of all these people and then all of a sudden you can't even take care of yourself, then everybody suffers. And I think that's taking that moment out to say, look, my health is just as important and I need to take time and do so. And I think that's the real challenge for a lot of women right now.
Yeah, most women don't want to take care of themselves, but you're exactly right. They're the sandwich generation at this point. They're taking care of their parents and their children, and everything's going haywire, and then all of a sudden, they go into menopause at the same time. So it's a rough roller coaster, but they have to find a way to put themselves first. That's key. And
like just like this question that's on here right now says, what do I do if my cortisol is really low? Well, one, you have to test. I mean, you don't know if your cortisol is low unless you test. You may feel like it is, but to me, that's a classic example of what I just said. The body's pretty amazing, because like if you're under stress, it's going to dump out lots of cortisol, and it's going to get you through the day because it's trying to do that fight or flight, and it's going to survive. But if day after day after day you beat down your adrenal glands, at some point they're going to be like, hey, enough's enough. And they start to shut it down because they're like, look, you need to chill. And that's those mornings you get up in the morning and you can't get out of bed but you're also wired to the point you can't sleep at night. And, I heard a recent lecture that I really took a lot of heart in. As women get older, their reproductive organs, their uterus and their ovaries and all, they don't produce the hormones like they should. And a lot of that hormone replacement, or a lot of the hormones the body are going to make, come from the adrenal glands. And the adrenals have to pick up that slack. And so if you're running constant stress, or when you hit perimenopause or menopause and you have had a lot of stress and your adrenals are not in good shape, the analogy was that determines whether you're going to slide into menopause or you're going to crash into menopause, because those adrenals have to pick up the slack. And if they can't even get you through the day with cortisol, because cortisol is the one hormone, if you don't make it, you die in about 7 days, you're going to really struggle with menopause. And it kind of ties into that whole stress thing.
Right. Exactly.
Here's a question. It says, does estrogen reverse or help with osteoporosis? What's the best? 56 and a minus 38 spine and hips. So, I think give me your thoughts on hormone replacement and bones in general as far as that goes.
Well, you know what? I think a lot of us don't know that our bones start to thin in your mid 30s, your early 40s. So when perimenopause begins, that's when your bones begin to thin. So it's absolutely important that we keep that balanced with estrogen, progesterone, and testosterone as needed at the time that you need them, along with exercise and along with vitamin D and vitamin K and all of the important minerals for your bones. So again, it won't work in a vacuum. Just taking estrogen will not reverse or treat osteoporosis, but doing all of those things, exercising, lifting weights, and of course getting your vitamin D levels optimal, that's what you need to help with osteoporosis. But estrogen
you're right.
is really important.
That's exactly, estrogen maintains, progesterone strengthens, and testosterone builds. And you mentioned something else. So you can give hormones, but if you got low vitamin D, then it's like your hormones don't do what they should. So that's where you really need to find a practitioner that's fully trained in this root cause approach to look at all the things that have an impact. I think that's super important. Got a couple more questions and we're going to wrap up. I know I've kept you on here for a while and it's been awesome to have you join me. And if you got questions, drop them in there. But it says, let's see right here. Do I have to do progesterone cyclically, 2 weeks on, 2 weeks off, in perimenopause with regular periods? So that perimenopausal woman that we see starts to have that progesterone, are you typically doing cyclic progesterone on those women?
Absolutely. So I usually cycle them anywhere starting day 14 or 15 till they have a cycle. Sometimes I have to start day 10. Sometimes I have to start day 12. So it's not written in stone. Again, it's very personalized for each woman. But yes, we do like to cycle 2 weeks on and 2 weeks off, just as your normal cycle should be happening.
Very cool. Well, you know what, Sakina, it has been so awesome. You and I talk this stuff every day. So it's It's just another thing for us. But I do think
cool before hormones were cool, Steve. Come on.
No, I agree with you. We've been doing it a long time.
A long time, long before it's become the thing. But I'm glad that it's out and everyone's talking about it now.
No, I agree 100% so much. And there's some really awesome comments there about thanking us for sharing our information. So if anybody listened to us today and they're like, hey, I want to find where these practitioners are. So remind everybody again where you're located at.
So I'm at Woodlands Wellness and Cosmetic Center in the Woodlands, Texas. So definitely come see me. And Steve is our best pharmacist that helps me along the way. He's been amazing for the last 20 years, helping me along this journey as well.
Oh, that's awesome. I really appreciate that. It's definitely, I think the best patients have the best outcomes when they can find a prescriber and a pharmacist and they themselves are bought in. Like that triad of that patient, prescriber, and pharmacist is really what creates great outcomes. And I know you and I have had game-changing stories with a lot of our patients as far as that goes. Well, once again, thank you so much for joining me. I really appreciate
you for having me. I really appreciate it. Thank you.
Yeah, and keep doing what you're doing. Like you said, we're not going anywhere. We're going to make sure that those women that are in perimenopause and menopause get taken care of. And I know you'll keep doing the same thing.
Thank you, everybody.
Have a great day. Take care.
You too. Bye-bye.